Okay, a very good afternoon, everyone, and welcome to our medical department CME, still conducted virtually via the Zoom platform. So today we have the privilege of having the neurology team to grace our platform, and they will be presenting to us on acute stroke and mechanical thrombectomy. Our presenters today will be Dr. Daniel and Dr. Arjun, and supervised by Dr. Chia and Dr. Sheila, our neurologist. So if you have any questions for any of the presenters, you may feel free to type into the chat box or ask them at the end of their presentation. And after the CME is over, there will be some few short announcements from the department. All right, so hope everyone will stay till the end. Okay, and let's see, we have about 21 participants. I think more will join in along the way. So I think without further ado, if our presenters are ready, I will hand it over to you all to start the CME.
Okay. Hello, good afternoon, everyone. Today, I'm Daniel, and Dr. Arjun and I will be presenting on acute stroke, which is the wake-up stroke and mechanical thrombectomy, supervised by Dr. Chia and Dr. Sheila. So outlines of presentation today will be based on the thrombolysis protocol in the acute stroke, the wake-up stroke, and the mechanical thrombectomy. So some of the workflows and the targets for the stroke activations will be our aim is to door to needle time will be less than 60 minutes. So in which patients with suspected stroke arrive at the hospital, in the first 10 minutes, the initial ED team will do an evaluation based on patient history, the lab work initiation, and NIHS assessment. So within 15 minutes, the stroke team will be notified, including the neurologic expertise. In less than 25 minutes, a CT scan should be initiated. And within 45 minutes, a CT and the lab report is actually interpreted. And by 60 minutes, we have to activate the tissue plasminogen activators is actually given to the patient who is actually eligible for it. So some of the Queen Elizabeth Hospital stroke protocol, which was actually updated in 2018 itself, those patients with suspected stroke in ED with quick, fast assessment. So first of all, then so that will be based on the facial asymmetry, arm weakness, speech, and actually the time. Then we'll move on to ABCD score, which includes the airways, breathing, circulation, and including DXT. Then we activate the thrombolysis. So actually, the office hour and non-office hour will be to the neurology team now. And we do not need to wait for the CT scan to activate the thrombolysis. Then we will proceed for CT or CTA brain urgent in the ED. And based on the Rosier score or the FAPS questionnaire to assess the possibility of stroke, those with a low possibility of stroke with normal CT when they proceed for MRI if necessary. But if those with a high possibility of stroke, then we actually assess them for the eligibility for the thrombolysis. And if the patient is actually eligible for it, then we will proceed for thrombolysis. And if not, then we would not proceed for thrombolysis. So this is actually the stroke activation form, which includes the date and time, the door time, which needs to be documented, the activated time, which is actually the ED team activated the stroke alert, which need to be documented, and the CT time, patient's name and IC, the age, gender, dominant hand, and the weight. The presenting complaints, the time of onset of the stroke, any allergies needed to be documented now as well. Then the blood pressure, pulse rate, SpO2, DXT, the stroke syndrome, NIHS score, MRI is a modified ranking scale score, and the neurological findings. And some of the other investigations includes the ECG, X-rays, the imaging findings, and the expect score. And the treatment if the IV recombinant tissue plasminogen activators, which is in this case is actually out of place, is given or not given. If it's not given, then you need to state the reason why and when was out of place given. And we need to include the inclusion criteria, exclusion, and the informed consent, which I will explain in a while. The total dose given and and the completion time. And if actually more than 1 hour, we need to specify the reason why. And subsequently, the patient will be admitted either to the ICU, the acute stroke unit, or the general ward. So this is the pool IV IVTs, IV thrombolysis trials, which actually the brain is, the time is brain based on the time from the stroke symptoms onset to the initiations of the IV RTPA. So you can see that actually based on the odd ratios, that actually shows more favorable outcome in those patients which was given IVT within actually less than 90 minutes. And more than that, within 90 to 80 minutes, actually the outcome actually reduces actually. So some of the thrombolysis criteria, step one, we need to talk about, we need to look into the inclusion criteria. So the age of more than 18 years old, the history, the symptoms, the CT consistent with the ischemic stroke, and the time within 0 to 3 hours or 3 to 4.5 hours with additional criteria. So if the thrombolysis is within 3 to 4.5 hours, we need to look at the age of less than or equal to 80 years old. There's no concomitant history of diabetes and prior stroke, NIH score of less than 25. There's no history of taking anticoagulant and an MCA infarct size of less than 1/3. And the step two, we need to look for the exclusion criteria. So some of the exclusion criteria includes like the aspect score of less than 8 or the infarct size of more than 1/3 of the MCA, CT scans of intracranial hemorrhage, subarachnoid hemorrhage, mass effects of findings not consistent with ischemic stroke, history suspicion of subarachnoid hemorrhage, stroke or serious head trauma within the preceding 3 months with a low glucose of 2.7 or hyperglycemic of 22 millimole per liter. Any past history of any type of brain hemorrhage like the intracranial hemorrhage, subarachnoid hemorrhage, or intracranial aneurysm of more than 1 cm, AVM or tumor, intracranial or intraspinal surgery within 3 months, GI hemorrhage or GI malignancy within preceding 21 days, or any major surgery or serious trauma within the preceding 14 days, or any lumbar puncture within 7 days. So, or any arterial puncture at the non-compressible site within the preceding 7 days, systolic blood pressure, which is important, of more than 185 millimeter mercury, or diastolic blood pressure of more than 110 at the time of treatment. So we need to control the blood pressure if we ought to give IV afterplace to the patients. And if any active interval bleeding, coagulopathy of INR more than 1.7, APTT of more 1.5 times normal, or platelet count of less than 100,000, or the use of low molecular weight heparin within 24 hours. Or if the patient is taking any DOACs, then we need to consider that as well. And bacterial endocarditis, any aortic arch dissections, or NIH score of less than 4 may be considered in isolated significant symptoms. But yeah, so if, yeah. Some of the warning signs that we need to look for is that if, let's say, the patients have a left heart thrombus or MI within the 3 months, or any homeostatic defects, including those secondary or severe hepatic or renal disease, diabetic hemorrhagic retinopathy, or other hemorrhagic ophthalmic condition, pregnancy or menstruation. Actually, in this case, thrombolysis can be considered, but we need to consult the neurologic team. Then we quickly have to discuss with the family and the patients and to take a quick consent. A verbal consent will suffice in this case. So as you can see, the thrombolysis, if it is given within the 3 hours, the number needed to treat is actually 8. But if it's within 3 to 4.5 hours, the number to treat actually increases significantly to 14. So as soon as the IV thrombolysis needed to be given, it should be given as soon as possible. Okay, so a well-documented verbal consent is actually enough if the delayed written consent is actually anticipated. So this is the modified ranking scale score, a ranking scale. So a score of 0 is actually there's no symptoms at all. Score of 1, there's no significant disability despite the symptoms, and able to carry out the usual activities. Score of 2, there's slight disability, unable to carry out all previous activities, but able to look after own affairs without assistance. Score of 3, there's moderate disability, requiring some help, but able to walk without assistance. Score of 4 is a moderate to severe disability, unable to walk without assistance, and unable to attend to own bodily needs without assistance. 5 is actually severely disabled, which is like bedridden, and 6 is actually dead. Okay, I pass on to Arjun.
So I'll be continuing from step 4 onwards. So once we've already established that this particular patient needs thrombolysis, we should ensure there's 2 large bore IV cannulas. If the patient is on any anticoagulation like warfarin, vitamin K should be given, or if the patient is on any novel anticoagulants, we should also give the reversal if it's available. We should avoid any central lines, arterial lines, NG tubes or Foley catheters in the next 24 hours unless it's truly indicated. So at point of contact, patient would have all his or her bloods done, for example, like the full blood count, the RP, LFTs, and also a random blood sugar. The INR is important if the patient is previously on any anticoagulation. Otherwise, it's not really that important. We should technically cross-match for any blood products in anticipation of any hemorrhage, and a baseline ECG and chest X-ray is also required. Once we've already established the need and we've already done the preliminary investigations, we should also then calculate the patient's weight. If the patient is morbidly obese, we should use his ideal body weight. Otherwise, we can use the dose of 0.9 mg per kg. Maximum we can give is only 90 milligrams. 1 vial of alteplase is 50 milligrams. So in every thrombolysis bag, there is 2 vials, which will equate to about 100 milligrams. However, the maximum amount that is given is only 90 milligrams for whatever weight the patient is. We administer 10% of the total dose as bolus over 1 minute, and the remaining will be given as an infusion over 1 hour. We should watch for any angioedema, which is the known complication or side effect of alteplase, by inspecting the mouth and tongue at intervals of 30 minutes, 45 minutes, 60 minutes, 75 minutes, and 90 minutes, basically every 15 minutes. In retrospect, if the alteplase has already been constituted, but then you don't actually give for this patient for any particular reason, you can actually store this in the fridge for about 24 hours. Ideally, each patient who has had thrombolysis should be admitted to the acute stroke unit, like the ICU, HDU. Vital signs should be checked every 15 minutes for the first 2 hours, 30 minutes for the subsequent 6 hours, and hourly for the next 24 hours. GCS hourly for the first 24 hours as well. The NIHSS scoring at point of thrombolysis, at 2nd hour, 24 hours, and also after 7 days. Tight blood pressure control is very much needed to prevent hemorrhage in these patients. Systolic blood pressure of lesser than 180 or diastolic blood pressure of lesser than 105 is what we actually aim to give. And sugars should be between 5 to 8. All right, so if the patients actually develop any neurological deterioration, any new onset of neurology as compared to the point of contact, or if the NIHSS drops by 4 or more, we should suspect of hemorrhage, basically any intracranial hemorrhage. If the blood pressure is not within the range that we target, we can actually give boluses of labetalol, and if it's not controlled with boluses, we can give infusion of labetalol to ensure that the blood pressure is within the target range. As per usual, monitor for complications of labetalol like hypotension and bradycardia. Basically, it's the same, just ensure the blood pressure is lesser than 180 by 105. If labetalol is not enough, we can add on with sodium nitroprusside. And as usual, monitor the BP every 3 to 5 minutes and titrate accordingly. If we suspect the patient has an intracranial hemorrhage or a side effect or a complication related to thrombolysis, we should, by evidence of new neurology, new headache, any acute hypertension, any symptoms of increased intracranial pressure like nausea or vomiting, we should immediately stop alteplase infusion if the infusion is still ongoing. take all the baseline blood investigations in anticipation of an op, immediate CT brain, and we should also cross-match 20 units of cryoprecipitate if we actually have to administer it to actually halt the bleed. Let's say if we do a CT brain and there's no bleed, we do not recommence the alteplase infusion. We just stop because this patient is at high risk for developing a bleed. If a bleed is present, we should know whether it's the bleed parenchymal hemorrhage type 1 or type 2. Type 1 is basically the hemorrhage constitutes less than 30% of the infarcted area with very minimal mass effect. Type 2 means that the bleed occupies more than 30% of the infarcted area with a significant midline shift. Okay, so if this patient actually requires intervention, or for example, this patient has a bleed, we should give cryoprecipitate emergently, 10 units over 10 to 30 minutes. And then we check the fibrinogen level 1 hour later. If the fibrinogen level is less than 200 milligram per deciliter, we should repeat cryoprecipitate dose as required and upon hematology consult. You can also give IV tranexamic acid infusion or E-aminocaproic acid infusion as well. E-aminocaproic acid is anti-fibrinolytic agent. We should definitely update neurosurgical team and also to get the hematological team involved as well. If the patient develops any other bleeds other than intracranial hemorrhage, for example, if he has had ABG taken at point of contact, probably the ABG site is bleeding, we should try to halt the bleed by giving mechanical compression or try to give any occlusion to prevent the bleed or to halt the bleed. However, if this is not adequate, we should then the same pathway of how we actually manage intracranial hemorrhage to be instituted for this patient as well. All right. These are some risk factors we should actually take into account in anticipation of this particular patient is at a higher risk for bleed or not. At point of contact, if the CT shows more than 1/3 MCA territory infarct, or if at point of contact the patient has severe hyperglycemia or any history of diabetes mellitus, the time to treat, for example, we treat this patient a bit later on, or the symptoms onset is quite, the severity of the symptoms is quite severe. If the patient presents with a very high BP at point of contact or low platelet, or even an older gentleman or lady, these patients are at high risk for developing hemorrhagic transformation. That is all for the thrombolysis part. We shall now move on to our respective sub presentations. So I'll be talking on wake-up stroke. So I think we have just finished talking about how we actually sorry, yeah, just a little bit of oh, sorry, before we move on to the next topic, does anybody have any questions to ask? Can you all hear us talking?
Yes, we can. Loud and clear.
Right. Okay, sure. Thanks a lot. Okay, so next we will move on to wake-up stroke. Basically, we have just completed how we will approach a patient who presents with acute ischemic stroke in the emergency department. So once this, traditionally we know that thrombolysis is the standard medical treatment for any acute ischemic stroke that happens within 4.5 hours of the onset of symptoms. But studies have shown up to 30% of patients who present with stroke, we do not actually know the time of onset, because frequently these stroke symptoms actually arise once the patient gets up from sleep. This is what we call as wake-up stroke. And such patients actually we exclude from treatment because we don't exactly know when the stroke actually happens. So for example, if the patient sleeps at 9 p.m. and he gets up the next day at 9 a.m., we take that as 12 hours. And let's say he comes to ED at 10 a.m. So it's already been like 13 hours since we've known him to be normal. So we generally say that this patient is not appropriate for thrombolysis because we do not know when the stroke actually happens. But actually, studies have shown that a substantial proportion of strokes that are evident after sleep probably actually only occurred in the last few hours of awakening, meaning to say that if we actually knew the time of onset and we can actually determine if this stroke has happened at which time, most of these patients, up to 30%, actually will be eligible for thrombolysis. Okay, so how do we know if these patients are within the within the IVT period, which is within the thrombolysis period? I would say IVT equates to thrombolysis. Okay. Sorry. Okay, so there is something called MRI mismatch pattern that was chosen because this actually suggests that the stroke has occurred within 4.5 hours. There's a study called the pre-flash study, which actually is a study that was published in 2011, whereby patients who presented within 12 hours of stroke onset in the years 2001 to 2009, they were actually included in this study. So all these patients who presented within 12 hours of stroke-like symptoms, they were subjected to an MRI flare and an MRI DWI. So this study has concluded that those patients who are within the 4.5 hour period from when the stroke has happened, they will have a mismatch between the MRI DWI and MRI flare. Meaning to say that, for example, this gentleman A who comes in with a stroke, for example, as I said, he went to sleep at 9 o'clock and then he actually got up the next day 9 a.m. He came to ED at 10 a.m. and we actually did an MRI DWI and MRI flare, and we see there's a mismatch. In DWI, we see an acute lesion. However, in flare, we don't see. This actually shows that this patient is within the 4.5 hours of a stroke onset, and actually he is actually fit for thrombolysis. So this mismatch between the DWI and flare has been a criteria for those who presented with wake-up stroke. Hence, if there is a mismatch, this patient is deemed to be within the 4.5 hour of symptoms onset. This is something new because as of now, we only use CT scan. But in the future, we actually hope that all patients who present with acute stroke symptoms would be subjected to an MRI, flare and DWI, so that we can actually institute IVT for those who actually really deserve it, and not just take from the last when he was well seen. So DWI and flare mismatch indicates there is acute ischemic event. However, there is no infarct. Basically, there is penumbra, but there is no core. Would those patients with this mismatch benefit from intravenous thrombolysis? So there's another study that is called the Wake Up trial that actually, basically this Wake Up trial concludes that those patients who actually present with, who actually have DWI and flare mismatch, if we actually institute IV alteplase or thrombolysis for these patients, there's a good outcome for them. Out of 503 patients who were enrolled in this study, 254 were assigned to thrombolysis and 250 received a placebo. The treatment in the alteplase group, actually 53% of them had a good outcome at 90 days. Their modified Rankin scale was within 0 to 1, meaning that they had no disability. As compared to the placebo group, only 41% actually had a good outcome at 90 days. So 53% versus 41%, there is quite a significant improvement at 90 days. So this trial was actually successful. There's another trial called the Extend trial, which whereby they actually used a different imaging modality. Instead of using the MRI, they used a CT perfusion. So this trial also actually showed that patients who were given thrombolysis with, basically the recommendation is that for patients with acute ischemic stroke on awakening from sleep, who were last seen well more than 4.5 hours earlier, however, they actually have an MRI DWI flare mismatch, these patients are recommended to receive intravenous thrombolysis with alteplase. The quality of evidence is high and the strength of recommendation is strong. So basically, CT scan is just not the right modality for these patients, and MRI, DWI, and flare should be done to actually know exactly when the stroke happened. By having a mismatch, we can actually know this. That's all from me. Any questions that anybody want to ask? Dr. Sheila is prepared to answer.
Hi, afternoon. Gordon here. Can I ask, so in QE we have extended for our thrombolysis to wake up stroke, is it?
Sorry again. I'm sorry, we couldn't hear your question again. Sorry.
I mean, last time I used to remember when Dr. just started, we only stick to those who fulfill the criteria within 4.5 hours. So for now, have we extended to wake up stroke as well? Our criteria?
Oh, okay. Thank you for the question. I think at the moment, because of the ongoing COVID pandemic, it's a bit difficult for us to get MRI. Because for MRI in acute stroke, right, you are, how to say, they still require RTK, COVID, right, at the moment?
Yes.
So if you want to wait for RTK result, it will take about 45 minutes to 1 hour. So it will be a bit difficult. We are hoping that actually we are introducing this so that in the future, maybe by the end of the year or even in a few months when the pandemic is coming down, then we'll try to pursue this. And even if we want to start using MRI DWI flare, we can only start, how to say, we can only initiate it during office hour. Yeah. So the reason of this, we are introducing this is for the future preparation. It's something like just to want to let you all know that stroke is evolving. The acute treatment for stroke is evolving. So now even those who came in with a wake-up stroke or stroke of unknown onset, we are still able to give them a proper treatment to reverse the disability. Yeah.
Thanks, Sheila. Great to hear that.
So in the future, we can adopt these imaging techniques to help those patients.
I see. Is CT perfusion an alternative for this MRI?
Yeah, CT perfusion, yeah, according to the EXTEND trial, but you have to know that the CT perfusion, the imaging that they are using AI, artificial intelligence. So the perfusion, the computer system, the perfusion map, right, is being automated, calculated. And the software that they are using is a rapid software, which is of research base. So when you do the perfusion, right, the computer, the software, they will give the calculation automatically. So you can know the penumbra, you can know the code, in fact, more accurate compared to our CT perfusion software here, in which we need to use eyeballing system. So it's a bit difficult for us because we don't have the automated software. So to make our life easier and to make, how to say, to make it more easier for us, we actually prefer the MRI for wake-up stroke.
I see. Okay, thank you.
I mean, all these things is advanced imaging in which we can hope to adopt it, but it just depends on the availability of our imaging and also the, how to say, the technician support, all these things. So in the future, maybe we will change it to CT perfusion if we're able to get the software or more advanced CT perfusion. So it's something that evolving. Yeah. Okay. I think we can proceed to mechanical thrombectomy.
Okay, thank you. Thanks, thanks Arjun and Dr. Sheila for the explanation. So I'll move on with the mechanical thrombectomy. So mechanical thrombectomy is something which has not been started in Queen Elizabeth and something that we ought to start somehow, hopefully in the future. So the current standards of therapy of acute ischemic stroke still remain to be the IVT, which is the IV thrombolysis. And the usage is actually very much limited with a narrow therapeutic window of less than 4.5 hours. And it has a longer recanalization time and actually very poor revascularization rates in the large vessel occlusion is in about 30% only. And sadly, it's actually only 10% of acute ischemic stroke patients are eligible for IV thrombolysis. That's why most of the time when a stroke alert is activated, not all of them actually are eligible for IVT. So in one of the trial, which is the PROACT2 trial, which looking into the MCA occlusion, is actually a PROLASE in acute cerebral thromboembolism 2 trial. So this trial looking into intra-arterial versus intravenous thrombolysis. So actually, the intra-arterial actually achieved a much more favorable outcomes in 90 days based on the ranking, modified ranking skill score of 40% as opposed to 25% in the IVT group of patients. And the randomized studies, which was conducted since November of 2014, looking into the endovascular thrombectomy for large vessel occlusion, actually it shows clinical benefit when it was performed within 6 hours after the stroke onset. As what we know, time is brain, so thrombectomy is very much time dependent. So we proceed to the thrombectomy immediately after the alteplase. So how do we identify large vessel occlusion? So do we use the NIHSS cutoff of more than 6 to tell us that actually this patient most likely having a large vessel occlusion? But in actual fact, it's actually some of the patients with mild clinical syndrome still have a substantial incidence of large vessel occlusion. Approximately 10% of them with NIHSS less than 6 still, and these patients are at risk of subsequent clinical deterioration. So do we do CTA for all of them? Usually for mechanical thrombectomy, we do need a CTA for confirmation to say that this patient is most having a proximal occlusion. So which arterial occlusion are suitable for thrombectomy? So all the trials actually included intracranial internal carotid artery and MCA occlusion is in the M1, and relatively few M2 occlusions were actually treated because they're actually quite distal, and there's no anterior PCA or basilar artery occlusion were included in the previous trials. So at this moment, we are looking into internal carotid and M1 segment and rarely into M2 segment. So let's look into some of the studies which was done in the early window randomized clinical trials. So early means that they actually is been done in patients presented with stroke less than 6 hours. So these are a few studies which most of them are published in 2015. There are 5 studies which was published in 2015, and 2 of them is actually published in 2016 and 2020. So looking into thrombectomy versus the medical treatment in 0 to 6, 8, and 12 hours. So the Mr. Clean trial, which was done in Netherlands, is a randomized trial for intra-arterial treatment for acute ischemic stroke. Where these patients are randomized within 6 hours with NIHSS score of more than 2, with a proximal arterial occlusion. So it shows that actually those given intra-arterial urokinase and mechanical thrombectomy has plus the best medical treatment shows a more superiority as compared to those only receiving best medical treatment. The Escape trial, which is the randomized assessment of rapid endovascular treatment, this one actually takes up to 12 hours with an NIHSS of more than 5. Again, it shows that a more superiority in those patients treated with endovascular treatment. And the Extend 1A trial, this one, it randomized patient up to 4.5 hours with no NIHSS restriction. And this includes, this one includes a CTA with a CT perfusion study. So it shows that those with mechanical thrombectomy plus intravenous therapy actually shows a more superiority than those compared to those with receiving intravenous thrombolysis. So a SWIFT prime trial, which is the stent retrieval thrombectomy after intravenous thrombolysis versus the TPA alone in stroke, again it shows a more superiority in the stent retrieval thrombectomy than the IVT alone. Same goes to the Rivascat trial as well. And the TRACE trial is the mechanical thrombectomy after the IV alteplase versus the alteplase alone after stroke. Again, it shows there is a more superiority when it's combined with the mechanical thrombectomy. So the 2020 Resilient trial, which is the thrombectomy for stroke in the public health care system of Brazil, again, it shows that actually thrombectomy shows a more superiority. So the primary endpoint is actually looking at the modified ranking skill score at 90 days. So across all the studies, actually all of them says that actually those receiving intervention is better than those in the control group. So intervention are those have received a mechanical thrombectomy as opposed to those only receive either intravenous alteplase or those only receiving best medical treatment alone. So this is actually a meta-analysis looking at the from the 5 randomized trial. So the overall, the intervention group shows a better modified ranking skill score compared to the control group, and those receive alteplase prior to mechanical thrombectomy actually has a better outcome in terms of modified ranking skill score as compared to those ineligible for alteplase for various reasons. And this table actually favors intervention. Actually shows that there's actually favors intervention as compared to those in the control group. And for the imaging features and safety and efficacy of endovascular stroke treatment, again, it shows that actually those receiving endovascular treatment actually has a better outcome as compared to those in the control group. So the guidelines of mechanical thrombectomy within 6 hours after the symptom onset, based on the AHA and ASA guideline 2019, actually there is 1,900 patients which was randomized looking into the anterior circulation large vessel occlusion with NIHSS score of more or equal to 6, aspect score of more than equal to 6, and a pre-stroke MRS of 0 to 1. So across all the trials, it actually those at 3 months of the MRS score, actually those treated with mechanical thrombectomy shows a more favorable outcome compared to those only receiving best medical treatment alone. So this one is actually some of the patient. So the patient population and technique within 0 to 6 hours. So so those patients receive mechanical thrombectomy with a stent retrieval. Either they meet the following criteria, like one, whether they have a pre-stroke MRS of 0 to 1, whether the causative occlusions were actually proximal, or there's an age of more than 18 and NIHSS of 6 and above, aspect of more than 6 and above, and can receive and the treatment can be initiated within 6 hours from the symptom onset. It actually has a class 1A evidence as compared to those only direct aspiration thrombectomy as the first pass mechanical thrombectomy, which has a 1B evidence. So let's move on to have a look at the IV thrombolysis. So those patients who are eligible for IV alteplase should receive IV alteplase even if the mechanical thrombectomy is being considered. It's actually a 1A evidence. So we should not delay the IV alteplase administration, even though there is actually a mechanical thrombectomy service available in the hospital. And in patients under consideration for mechanical thrombectomy, observation after the IV alteplase to assess the clinical response should not be performed. Actually, it's a 3B evidence. And interestingly, actually, there is it may be reasonable to choose tenecteplase over IV alteplase in patients without contraindication for IV fibrinolysis who are also eligible to undergo mechanical thrombectomy, which is showing a 2B evidence. But I think Dr. Sheila later will talk on it. There's actually a newer study coming out recently and shows that actually tenecteplase is actually also can be given to patients if IV alteplase is not available. And the imaging study, whether this patient, it actually shows that when evaluating patients with acute ischemic stroke within 6 hours with an aspect score of more than 6 for mechanical thrombectomy, CTA or MRI or MRA is recommended in preference to performance of the additional imaging such as a perfusion study. Okay, let's move on to talk about the late window randomized clinical trial. So this one, there's two major studies looking into the late window randomized clinical trial. So the Dawn 2018 trial, which takes patient actually from 6 to 24 hours after the stroke with a mismatch between deficit and infarct. And the Diffuse 2018 trial actually looks at the thrombectomy for stroke from 6 to 16 hours with selection by perfusion imaging. So it's a bit complicated. So the thrombectomy beyond 6 hours time window in the Dawn trial actually is looking at the clinical mismatch, which is the difference between the severity of the clinical deficit and the infarct volume. So with mismatch criteria, they're actually defined by according to the age of the patient. So they take 80 as a cutoff point. So in those more than 80 years, and all of them actually have a NIHSS score of more than 10. So those more than 80 years old, with NIHSS score more than 10, they take the core infarct volume of 0 to less than 21 cc. So if the patient is less than 80 years old, NIHSS score of more than 10, and the core infarct volume 0 to less than 31 cc, they will be randomized into the trial whether to receive a thrombectomy or this patient will receive a best medical treatment only. And in those age less than 80 years old with NIHSS more than 20, and the core infarct volume they take at 31 to less than 51 cc. In the Diffuse 3 trial, which looking into CT perfusion or DWI, it randomized this patient based on this criteria, they will be either randomized into the thrombectomy or the best medical treatment. So they'll take the core of less than 70 mils, mismatch ratio of more than 1.8, and a mismatch volume of more than 15 mils with an NIHSS score of more than 6. So as you can see, based on the primary, you can see those who randomized into the thrombectomy group, they actually shows a more favorable outcome in terms of modified ranking skill score at 90 days. So we'll move on to talk about the acute stroke pathway in the Queen. So at this moment, those patients with a last known onset of actually with a symptoms onset of less than 6 hours. So first we will perform a CT brain or a CTA from arch to vertex. So those less than 4.5 hours with no large vessel occlusion, we will proceed with the IV thrombolysis. Those with a large vessel less than 4.5 hours with large vessel occlusion, we will give the patients a IV alteplase plus the mechanical thrombectomy. So those 4.5 hours to 6 hours with a large vessel occlusion, they are only eligible for mechanical thrombectomy. Then that 4.5 to 6 hours with no large vessel occlusion, this patient will receive medical treatment. So how do we know that whether this patient actually eligible for IV thrombolysis with those with expect score of more than 7, with NIHSS score of more than 4, or NIHSS less than 4 with disabling deficit? So, but however, actually something that we have not advocated are those actually 6 to 24 hours with NIHSS score of more than 6. So if those, we first will perform a CT brain first, then a CT perfusion, then a CTA from arch to vertex, and those with large vessel occlusion or mismatch, then we can refer them to the interventional radiologist and the NS team for EVT. And those, but however, if there's no large vessel occlusion, we can give them they can only receive a medical treatment. Okay. So.
Can we go back to the chart?
All right. So thank you.
Any question?
Any questions from the floor?
So no question.
Nobody asked, then I'll ask again.
Yeah, sure.
Actually, when will you suspect LVO? I missed that. I might have missed that point. When you suspect LVO, or when do you do a CTA?
Actually, ideally, when you want to activate stroke call, right, you should get a CTA arch to vertex for all your stroke activation, because it's traditionally we always think that those who has an NIHSS more than 6, the probability of them of having large vessel occlusion is higher compared to those who has a low NIHSS. But I think with all the upcoming articles, everything, right, they actually found that even those who has a minor NIHSS less than 4, the 30% of them actually also have a large vessel occlusion diagnosed through the CTA. So ideally, all patients should have a CTA arch to vertex.
So our radiology here is able to cater all stroke activation for CTA.
At the moment, if we ask for that, for acute stroke, especially during office hour, in which we think that the patient is an eligible candidate for mechanical thrombectomy, they actually agree for that.
Oh, okay.
That they need to talk, they need, how to say, they need neurology, they need stroke team lah, to request for it.
Oh, so CTA is for office hour lah, we can say for now.
Thrombectomy at the moment.
Oh, we have thrombectomy already.
Yeah. Dr. Ganesan is here, the IR.
Wow.
Yeah, he is trained in stroke thrombectomy.
Fantastic.
Intervention radiologist. So the reason the pathway that I put here is important for in-house activation, because usually our stroke activation is from casualty level. So our medical officer in-house during office hour, they should be aware that acute stroke activation, including mechanical thrombectomy, can be activated in the hospital. I mean, in medical ward or in any subspecialty ward. So just have to remember this, the in-house activation. And last time, I think previously we only activate the stroke if the clear onset is less than 4.5 hours. So now we are trying to extend it out to 6 hours, in which it can include the mechanical thrombectomy, especially during office hour. So just
correct me if I'm wrong. So the only way to detect LVO is through CTA, correct?
It's through CTA, yeah. But NIHSS is actually can guide you.
Yeah.
Those who has NIHSS 6 or more, they actually can guide you with, 6 or more, they actually, they have evidence, their probability of have LVO is high. But it doesn't mean they have like, it's something like, I just don't want to confuse. It's like only NIHSS more than 6 will go for CTA, because those who has a low NIHSS, like only 2 or 3 or even 4, they can have LVO, just that the risk is lower compared to those more than 6. But we also don't want to miss them.
A majority of our patients got high NIHSS more than 6, right?
Sorry?
Majority of our patients actually have high NIHSS more than 6, right?
It's a bit difficult to comment about it, because our casualty, their activation, they can activate a stroke with an NIHSS 2 or even 3. But as long as the patient has a very severe disability, it's like the patient can have an NIHSS of 3 to 4, but with a hemiparesis, very dense hemiparesis, or they have some homonymous hemianopia that prevent the patient to go back to their job, or to prevent the patient from performing their daily activities, we actually will consider intravenous thrombolysis also, even though the NIHSS is very, very low. But as long as it impacts the ADL, we actually will consider thrombolysis as well. Yeah. Any
Dr.
questions?
Sheila, Ng here. Just to clarify again, regarding this stroke pathway, right, is strictly for office hours, for the less than 6 hours, for MT.
For mechanical thrombectomy, we only do it during office hour and the clear onset of less than 6 hours. Because for those onset more than 6 hours, we need advanced imaging, like the one that presented by Dr. Daniel just now, the dome and diffuse, in which they need MRI and also CT perfusion. At the moment, our advanced imaging is still in
MRI
the infancy level.
So more likely MRI vis-a-vis CTP lah.
For more than 6 hours onset.
More than 6 hours. Okay.
For more than 6 hours onset, it's a bit difficult for us to go beyond that. Yeah, so we will concentrate on those less than 6 hours onset, in which they only need CT brain and CTA.
Okay.
To let patient for mechanical thrombectomy and IV thrombolysis.
Second question,
Yes.
more likely for Ganesan actually that the data for basilar artery occlusion LVO, for large vessel occlusion for basilar artery already came out already in the European Society. So are we going posterior circulation as well, or are we just going to purely just anterior circulation only?
For me, even the previous trial, basilar and also basic, right? They don't show any good evidence for EVT in those basilar artery occlusion. We still, the overseas center and also even back in HKL, they will still do endovascular treatment for basilar artery occlusion. And with the latest, I think, trial for attention done in China.
Yep.
They
China trial.
They actually even show that the outcome is better for intervention group rather than giving best medical therapy.
But are we moving there, or are we just going to focus on anterior circulation only for the time being?
As long as as long as you can get a suitable candidate, and NIHHS more than 6, and then there's a presence of LVO in the ICA, M1 or even basilar, I will try to refer for endovascular thrombectomy.
Okay, thank you very much.
Less than 6 hours, I will try.
For less than 6 hours for the time being lah. Okay.
For the time being, less than 6 hours and during office hour only.
Okay, bye.
Okay.
Thank you very much.
Okay. Any other questions? Okay. If not, I think we can close this session, and thank you for listening to us. Okay, thank you. Any question can just refer us. Yeah, just talk to us, especially the in-house activation.
Yep. Hikin has a question in the chat box.
There's a question in the chat box. Sorry, I didn't. What's the question?
Can we consider mechanical thrombectomy for the patients that present with stroke within 24 hours?
Can we cope? Hiking, I think at the moment we just go for 24 hours, during less than 6 hours, and also during office hour, because we only have 1 IR. And our equipment, the equipment for the mechanical thrombectomy, such as the stent retriever and also aspiration catheter, is still, I think at the moment, still low in stock. So we will try to do during office hour and with a clear onset of less than 6 hours, that without any advanced imaging. We try slow and then see how's the coping system. Then we will extend our service later. Okay.
Yeah, Dr. Shia, one more question.
Yes.
Do I need to quote 30K for them? Like how they do in Klang Valley? Do I need to quote 30K? No need.
At the moment, it's free. According to Ganesan.
Okay. Okay.
Ganesan is free at the moment. Yeah.
Okay. Thank you very much.
Okay.
Okay. Thank you very much to the neuro team, Dr. Sheila, Daniel, and Arjun for the very comprehensive presentation. So anyone has any questions, you all can give them a ring. Right. I think Dr. Ho has an announcement to make.
Hi, can anyone hear me?
Yep, can.
Just want to make a small announcement. By next week, our female medical ward up here will be closed down. The existing staff will be joining ID ward. So ID ward is opening, and any GenMed female patient will be absorbed into GenMed 1 ward lah. Just to let everyone knows lah. That is the movement of the ward uphill lah. For the male ward, we will still be the same at uphill for the time being lah. We'll wait for further news lah, for if any movement further. I think that's all for me lah. Thank you.
Okay. Thanks, Dr. Ho. I think there are other ward movements as well, like GenMed 3 will be aiming to move next week from 8th floor to 7th floor once the new ward is ready. I think still some touch up to be done. Right. And okay, just a quick announcement on behalf of MedQAH. So we are recruiting committee members for our upcoming programs, the medical update, which will be somewhere in August, and also medical night tentatively somewhere in November. If you're interested to be a committee member, you get benefits, so you can just get in touch with me or fill up the survey form and we will get in touch with you. Okay, so I think that's all for now. I think Dr. Tang appeared just now. Dr. Tang, you have any announcements?
Hi. Tang here from SP. I just want to promote the Sabah SP update that going to July lah. I think MedQAH member memang got discount to very welcome everyone to join the Sabah SP update. Okay, there's a lot of good talk, good lecture from very great speakers. So very welcome. MedQAH memang got discount if you participate. All right, thanks, Josiah. That's all I want to say.
And happy birthday to Tang.
Thank you.
Okay, thanks, Dr. Tang. Yeah, MedQAH members, you get a 10% discount, and you get also, if you haven't applied for anything else yet, you can make a claim for a grant, 100 ringgit for an event per year. So this is one of those that you can make full use of that grant amount. Okay, so I think we will come to the end of our session. We will end the session here today, and we will continue on next week. So the attendance sheet will be sent to your groups. Okay, so thank you everyone, and have a good day.